Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM, a cardiologist from Houston, Texas. This is cardiology seminars brought to you by Triple N Media. On our YouTube channel, we have more than 200 cardiology lectures. We welcome you to watch these cardiology lectures. And I also ask you to kindly subscribe to our YouTube channel so we can keep you abreast of our new additions to the cardiology lectures. The information provided here is for education and entertainment purposes only and is not a professional advice. If you want us to prepare a video on a particular topic of interest, please let us know. We will be happy to do the research and produce the video. I have a cardiology rotations manual prepared for nurses, students, residents, and fellows. So if you would like to get a copy of this book so you can enhance your learning experience during your cardiology rotations, I will tell you how you can get this book at the end of this presentation. The feature presentation for this seminar is ACLS VT-VFib algorithm. When you are making rounds in the hospital, somebody collapses. You hook them up to a monitor and you see a rhythm like this. What do? Panic? No, that's not going to help. I'll tell you exactly what you need to do, because this is going to be most frequently tested part of the ACLS during your ACLS exam and in question answers along with the case scenarios. All right, let us begin with the high quality CPR. Once you have a witnessed arrest or an unwitnessed arrest, what you do is you call for help. You give oxygen if it's available. Then you attach automatic cardiac defibrillate. Once you attach, you can analyze the rhythm. Once the rhythm is analyzed, you make a determination as is there a rhythm that can be shocked? Yes or no. From there we proceed. But this is the algorithm that is created by the ACLS team. It is pretty complex. It is comprehensive, and this little chart here is extremely important. So what I have decided is just break this into small segments and go through each one of these segments so that we have a very sound understanding of what is involved in cardiac resuscitation during a patient's collapse, or when a patient is having a ventricular fibrillation or ventricular tachycardia. Okay, let us begin with the first segment of this ACLS chart. And here is the first segment. So we give oxygen, we attach monitor pads to the patient, analyze the rhythm. Is there a rhythm that can be shocked? Yes or no? If the monitor says yes, the rhythm is shockable, the automatic defibrillator will tell you, get ready to shock. Once the machine is ready, you shock the patient. Immediately following the shock, you begin 2-minute CPR. This is where they are going to trick you time and again. After shocking the patient, what do? Check for the carotid pulse, check for the apical pulse, check for breathing, start an IV. No. As soon as the shock is over, you do 2 minutes CPR. No questions asked. After you have done 2 minutes CPR, if you have help, they can start an IV access. So let's kind of recap this again. You find a patient in a rhythm. You identify the rhythm and you feel it is VT or VF, which is shockable. If that is the case, you shock the patient. Then you follow that with 2 minutes CPR. If you are a one person, you do 1 person CPR. We're going to explain how it is done. If there is a second person, that person can start an IV access, but you do the CPR for 2 minutes. On the other hand, if the rhythm is not shockable, you look for asystole or pulseless electrical activity. And if there is no pulse or if there's only electrical activity, you can give them epinephrine and then you begin 2 minutes CPR. So see the difference in these two scenarios. If you have VT, VF, you shock. If you have asystole or pulseless electrical activity, you don't shock first. You first give epinephrine. After epinephrine, you start the 2 minute CPR. 2 minutes CPR. You got it. You repeat epinephrine every 2 to 3 minutes. At the same time, you get an IV access. After we have done the first step intervention, which is epinephrine in a rhythm which is asystole or pulseless electrical activity, and shock if it is VT or VFib. So that completes this first part of the chart. Now let's go to the next part here. Now this is the second part of the chart, and here we have the second part of the chart. This is covering this segment. So let's look at this segment. We started off here, VT, VFib, we gave the shock, and now we are at this place. After you do 2-minute CPR, you check for the rhythm. Is the rhythm shockable? You shock the patient for the second time. After that, resume 2-minute CPR. And during this 2-minute CPR, this is the second step, 2-minute CPR, you give epinephrine every 3 to 5 minutes. So the epinephrine comes here after the second shock. Consider advanced airway at this time. By this time, it's almost 4 minutes gone, so you have some help, so they can work on the advanced airway. After 2 minutes CPR, you check for rhythm again. If there's no rhythm, you go back. Is the rhythm shockable? No. If you have an established rhythm, then we're going to go down here and we will follow up on this particular box in a minute. If the rhythm is shockable, you do the CPR again and you go in circle. Every 2 minutes, you do CPR, you check for the rhythm, you shock, and you give medications. First time you give epinephrine, so second time you give amiodarone or lidocaine. Then you continue the cycle here in a shockable cycle. Whereas on the other side, if the rhythm was asystole or pulseless electrical activity, we talked about giving epinephrine, then doing 2 minutes CPR, then we check for the rhythm again. Is the rhythm shockable? If the rhythm is shockable, then this patient will come down here. If the rhythm is not shockable, then you continue the CPR until we get a rhythm that is shockable. If the rhythm is shockable and we shock, if we see the rhythm has returned to normal, come down here. If not, we follow step 5 and 6, which is here. From here we go to 5 and 6. It's not shockable. Then what we look at? If no sign of return of spontaneous circulation, that is ROSC, go to 10 and 11. 10 and 11 is this one, 10 and 11. If there is no rhythm. But if we are able to establish a rhythm, then we go to post-cardiac arrest care. Consider appropriate continued resuscitation. So this is in summary how you would approach VT-VFib. But in order to do this, there are a lot of things that are going on besides just shocking the patient and checking for rhythm every 2 minutes. Because we had to diagnose what's causing this cardiac arrest. We had to look at what kind of drugs can be given to these patients to sustain their blood pressure or rhythm. We had to look at the airways. So let us go and analyze each one of these individually, because that's when you get a comprehensive knowledge of how to deal with a patient who is having a ventricular fibrillation or ventricular tachycardia. Okay, let us start off with high quality CPR. They love to ask you questions on high quality CPR. What is high quality CPR? The chest compressions should be at least 2 inches or 5 centimeters. It should be at a rate of 100 to 120 beats per minute. Remember these numbers. Remember, they're all going to be questions. And allow complete recoil of the chest after each compression. Minimize interruptions between compressions and avoid excess ventilation. Change compressors every 2 minutes. If no advanced airway, use compressions at a ratio of 30 to 2. So if you are the only person there, you do 30 compressions, 2 breaths, 30 compressions, 2 breaths. You just memorize this. It may look stupid, but you want to get through this ACLS course. It's kind of annoying, taking this ACLS course every 2 years, but you have to do it. If you have access, you can monitor the quantitative wave capnography, see how the quality of CPR is making progress. If you have access, you can also get the intra-arterial pressure, looking at least 20 millimeters change in diastolic pressure. So that is the first part, the CPR quality. Now let's look at the next part here, and this is defibrillation. If you see a patient with VT or VFib, the best approach is to shock these patients. If you are using a biphasic defibrillator, the initial dose is 120 to 200 joules. If unknown, use maximum available dose, which is 200 joules. The second and subsequent doses should be equivalent or higher than the previous dose. So the second time you shock, the energy should be higher if it allows. If you are having a monophasic, go straight to 360 joules. Now let's look at drugs. The drugs that we have available are epinephrine, amiodarone, lidocaine for arrhythmia control. Epinephrine is for asystole and pulseless electrical activity. It is given like 1 milligram every 3 to 5 minutes. It can be given intravenously or through the intraosseous route or even through the endotracheal tube if you don't have access. Amiodarone, your first loading dose is 300 milligram bolus. The second one is 150 milligram dose. Remember these doses. Those are all going to be your answers to questions on your written exam. Lidocaine is 1 to 1.5 milligram per kg. The second dose is approximately half of the loading dose. Let's look at airway. Advanced airway is an important part of CPR, especially if you have adequate help. We want to make sure minimize closed circuit disconnections. When you have a closed circuit, minimize disconnections. That's going to cause hypoxia. Use intubator with the highest likelihood of first pass success. When you are in the middle of a CPR, you don't want somebody to say, okay, hold it, I'm getting it, hold it. No, you don't have time to hold it. If that person cannot do it, just continue with the CPR, use a vent bag mask and continue with the CPR. Consider video laryngoscopy. Endotracheal intubation or supraglottic advanced airway can also be used. Wave capnography will help us to identify how well we are ventilating the patient. Monitor the ET tube placement by listening to the chest. So often we forget to listen to the chest. Once advanced airway is in place, give one breath every 6 seconds. One breath every 6 seconds. In 60 seconds, 1 minute, that is 10 beats. 10 beats. When you are one person doing compression, 30 compressions, 2 breaths. Whereas if you have a machine that's doing the work, 10 beats, that is every 6 seconds. Chest compressions should continue at all cost. The next one, return of spontaneous circulation, ROSC. Check for the pulse, check for the blood pressure, and look at the carbon dioxide levels. Monitor the arterial pressure waveform. Monitor, and if inotropic support is needed, you start the inotropic support to maintain the blood pressure. The last part we have left here is we need to look for reversible causes. 5H and 5Ts. This is going to be another question on your written exam. You have to memorize this because you want to pass the ACLS exam. 5H. Hypovolemia, causing hypotension, shock, bleeding may be one of the causes. Hypoxia, pulmonary embolus and has severe hypoxia, they can go into VT, VFib. Acidosis. Acidosis can precipitate arrhythmias very easily. Hyperkalemia. Hyperkalemia is known frequently to cause ventricular arrhythmias and can degenerate into VT, VFib. Hypothermia is another condition. Hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, hypothermia. So these are the 5H. The 5Ts, tension, pneumothorax, tamponade. The chances are these are extremely rare conditions. Toxins you're going to see from time to time, especially if you're in a city hospital, you may see them more often. People coming with drugs, cocaine, and all kinds of cardiotoxic drugs. Other conditions are coronary thrombosis or pulmonary thrombosis, which can lead to hypoxia and ventricular tachycardia or ventricular fibrillation. So ladies and gentlemen, this is a quick summary of how we deal with a patient with a VT or VFib from the time we witness it. First, we give oxygen, yell for help, put the monitor, identify the rhythm, and then you decide which way do you go. Thank you so much for watching. On our YouTube channel, we have more than 200 cardiology lectures. You're welcome to watch them, and please do subscribe to our YouTube channel. This cardiology seminar has been brought to you by Triple N Media. If you would like to get a copy of my cardiology rotations manual, you can send me an email to drniknikam@gmail.com. That is drniknikam@gmail.com. Thank you so much for watching. This is Triple N Media. I am Dr. Nik Nikam from Houston, Texas.